Hello everyone. Today we will start with the next chapter of gastroenterology, which is physiology of absorption and selective malabsorption. So, what is the physiology of absorption? So, it is considered in three steps. First step, there is the breakdown of nutrients, materials present inside the intestine, such as fats, carbohydrates, and proteins. They will be broken down. Then they will be absorbed inside the intestinal cells, which are also known as enterocytes. And after that, it will absorbed into the blood as well as lymph. Then this is such a basic physiology of absorption. Now we'll move on the main chapter, which is physiology of GIT absorption. So the basic absorption, it takes in three stages. First is the luminal stage, second is the small intestinal mucosa, and third is the post-mucosal. In lumen, what happens? Most of the enzymes will come inside the lumen, such as peptidase, carboxypeptidase, trypsinogen, chymotrypsinogen, amylase, nuclease. They will come inside the lumen and they will start breaking down carbohydrates, proteins, and fats. After breaking down, it will be absorbed with the help of enterocytes, which has presence of villus. Villus is a singular and vena is plural, which is brush bordered, and it also contains enzyme, and it will help in the absorption of materials which are present inside the lumen into the enterocytes. After that, these nutrients are passed on to the post-mucosal layer. In post-mucosal layer, mucosal epithelial cells are present, which will deliver these nutrients directly to the blood as well as lymph. In lymph, it will deliver majority the fat, and in blood, it will deliver carbohydrates and proteins. So, on the basis of anatomy, we can classify the absorption into two categories. Like there is small intestinal absorption, but it is in small intestine we have two parts. First is the proximal, then is the distal part. The proximal part consists of 2/5 and the distal part is 3/5 as it is mentioned here. And the proximal part, the maximum absorption takes in the proximal part, and proximal part consists of duodenum and jejunum. Then there is the distal part. Distal part is the 3/5. It is the majority of part, and it consists of ileum. Ileum has specific exclusive absorption where there is absorption of bile acids, vitamin B12, and magnesium plus 2. They're exclusively absorbed inside the ileum. On the basis of histology, we can classify there are four layers of intestine. First there is mucosa, then there is submucosa, then there is muscularis, and then there is serosa. So first layer, which is mucosa. Mucosa has presence of enterocyte cells, which I have told you that are the cells of the intestine, and has presence of villi. This villi will help in absorption of majority of nutrients inside the enterocytes. And this villi is surrounded by both sides with a crypt. This crypt is called as the crypt of Liberkine. And this crypt of Liberkine has presence of three cells. First cell, this is Paneth cells. Then there is enteroendocrine cells, and then there is goblet cells. What does Paneth cells do? Paneth cells, it is responsible for majority the immune response. So in immune response, what they will do? They will majoritarily secrete this lysozyme, they will secrete alpha defenses, and they will secrete this phospholipase A2. What will enteroendocrine cell do? Enteroendocrine cell, they will secrete hormones, and then they will tell what should be the mortality of the small intestine, how should the peristaltic movement conducted. And goblet cells, we all know it, they will secrete mucus, and mucus will prevent the corrosion of the small intestine. As we all know that this small intestinal layer, this layer always get replenished in every 2 to 3 days, like 48 to 72 hours. It is written here, this continuous renewal. Every day it will get replenished. So this mucosal layer has further two divisions, which is lamina propria and muscularis mucosa. Lamina propria is the loose connection. It has presence of glands and blood vessels. And then there is muscularis mucosa. Muscularis mucosa has presence, it is tightly bound. So it is written as tight attachment. And then there is one note, placi circularis. What is placi circularis? There are folding like structures present on the laminar layer inside the small intestine. They are called as placia structure. So visible mucosal folds on luminar surface of small intestine. Then there are cells, intestinal cells of Kajal. Then this intestinal cells, what they will act as pacemaker. Pacemaker, they will send electrical impulses like the heart. There are two nodes, SA node, AV node. They are sending one is pacemaker, SA node. So it will act the same way. It will send electrical impulses inside the small intestine, and hence will be responsible for the peristaltic movement. Then there is second layer, the submucosal layer. Submucosal layer has the presence of Brunner's gland and Peyer's patches. Brunner's gland, it secretes alkaline secretion for neutralizing the acid inside the duodenum. Then there are Peyer patches. It is present inside the ileum. Peyer's patches, microscopic structure, lymphoid aggregation. And in typhoid, this is good clinical case. In typhoid, it will cause hypertropia. Hypertropia means increasing in cell size. Cell size is increased in hypertropia. Then again, two layers are there, muscularis propria and serosa. Okay, fat absorption. How does fat gets absorbed? So for absorption of fat, what should we learn first? We should learn how to break down the fat. So we will learn first how to break the fat. So here triglyceric acid is present and pancreatic lipase will come here. Then the lipolysis process will be occurring and it will be converted into the triglyceride will be converted into fatty acid, glycerol and phospholipids. Then this fatty acid is again acted by bile salts and then this bile acids. Then these bile acids will convert this fatty acid into micelles, and these micelles will get passively absorbed with the help of passive diffusion inside the enterocytes. Enterocytes are the intestinal cells. Then bile acid physiology. How does this bile acid get formed? So the precursor of bile acids is cholesterol. From cholesterol, the bile acids will get synthesized. Inside the liver, majority of the cholesterol will go, and then this alpha hydroxylase enzyme will act on this cholesterol, and then it will convert that cholesterol into primary bile acid, which is cholic acid and quinodeoxycholic acid. Quinodeoxycholic acid. And this quinodeoxycholic acid and cholic acid, they will get conjugated. Before secretion, these bile acids are always conjugated. So for conjugation, glycerine and taurine will be used. This glycerine and taurine will conjugate cholic acid and quinodeoxycholic acid, and it will be converted into bile salts. These bile salts will be majority stored inside the gallbladder. And from gallbladder, it will be secreted in these three parts. First, inside the duodenum, then ileum, then colon. It will move further. So in D2, why it is written D2? Because it is secreted directly into the second part of the duodenum. Duodenum is divided into three parts. In the second part, it is secreted, and there it will help in the formation of micelles. I have told you how it will help in the formation of micelles. Look here, it will convert fatty acid into micelles, and then the micelles will be absorbed with the help of passive diffusion. But when it will go in the ileum till the terminal part, 95% of this will be getting reabsorbed. And after getting reabsorbed, it will directly go inside the liver, back to the liver. In colon, what will happen in colon? In colon, this conjugated bile salts will be converted into deconjugated bile salts, and deconjugated, then it will change its form. Like the cholic acid will be converted into deoxycholic acid, and this quinodeoxycholic acid will be converted into lithocholic acid. After that, defects in luminal absorption. Okay, I will tell you how the defects were. So if there is defect in this pancreatic lipase, if the pancreatic lipase does not act on triglyceride, so it will cause an issue. If this bile acids does not act on fatty acids, it will again cause issue. So these issues are referred here as defects in luminal absorption. So this pancreatic lipase, it is due to absence of pancreatic lipase is due to this chronic pancreatitis, and this bile acid is due to bile acid defects. So the same thing we will be learning here. In chronic pancreatitis, it affects pancreatic lipase, so the lipolysis step is affected. So it will not be converted into fatty acid, so we cannot absorb that material. In bile acid defect, what will happen? There are four reasons that the bile acids secretion is causing a defect. So first is the synthesis, second is the early deconjugation of small intestine, early deconjugation in small intestine, third is reabsorption, and the fourth is secretion. So first we'll go on to the synthesis. If there is defect in the synthesis of this bile acid, then they will call it as cirrhosis. If there is cirrhosis, there will be no synthesis of bile acid. And if early decongestion of bile acids inside the small intestine, what will be the reason? Because here I have told that this bacteria will do the decongestion of this bile acids. But now what is happening? There is early decongestion. So this is due to small intestinal bacterial obstruction. This is a very rare symptom. It does not occur, like generally it does not occur, but it is important. Then reabsorption. If the reabsorption is affected, the reabsorption, where does it occur? It occurs inside the ileum. There it is affected, so it will lead to this TB and Crohn's disease. And secretion, obviously the last part. If you have done everything, you have created bile acids and it is stored inside the gallbladder and it is not getting secreted, it will lead to primary biliary cholangitis and primary scoliosing cholangitis. Destruction of bile duct. Due to destruction of bile duct, then it will be stored inside the gallbladder. The mucosal phase of absorption. Now what is happening? In the mucosal layer, the absorption is hampered. So why it is hampered? Because the integrity of the membrane is destroyed. The membrane, which is getting replenished every 48 to 72 hours, it is not getting replenished, so the absorption is hampered, and it will lead to three conditions. These are global malabsorptions, by the way. Global malabsorption. First is the celiac disease, second is the Whipple's disease, and third is the tropical spew. Then there is, now we will be moving on to the next thing, which is the post-mucosal phase of absorption. What happens in the post-mucosal phase of absorption? Whenever there is a primary absorption done inside the enterocyte cells, this enterocyte cells has presence of fats. This fat will be again reabsorbed inside this post-mucosal layer, so that is post-mucosal absorption. So here is long chain of fatty acid. This long chain of fatty acid is esterified. Why does this long chain of fatty acid get esterified? This is done to restore the fat which we have broken down inside the lumen of intestine. Listen again. We have broken down fats inside the lumen of intestine. Now we absorb that fatty acids, and these fatty acids are again restored inside our intestinal cells to form fat again, and this fat is again stored inside the adipose tissue. For that process, this esterification is required. But what will happen if this esterification is defected? The patient will be affected with A beta lipoproteinemia and intestinal lymphangiectasia. And if it gets formed into chylomicrons, it is then transported into intestinal lymphatics. That's it. Then there are types of fatty acids. There are three types of fatty acids: long chain of fatty acids, medium chain of fatty acids, and short chain fatty acids. Long chain of fatty acids consist majority of more than 12 carbon atoms. This medium chain consists of 8 to 12 carbon atoms, and the short chain consists of less than 8 carbon atoms. It is written here. I'll tell you, this medium chain of fatty acids and short chain of fatty acids, they majority does not require this breakdown things and all. They will directly get converted into chylomicrons, and they will get absorbed inside the enterocytes and then into the post-mucosal layer. This is the chart which I have given here. It is from biochemistry actually, so you can go through it. Then there is mechanism of carbohydrate absorption. But for absorption purpose, we need to break it down. We need to break down carbohydrates. So carbohydrates are majority present in the form of polysaccharides. This polysaccharides is then broken down into disaccharides, and then disaccharides are broken down into monosaccharides. Disaccharides are broken down into monosaccharides with the help of disaccharidases. These are the enzymes which break down these disaccharides into monosaccharides. So disaccharides are here like lactose, lactase, maltase, sucrase, trehalase. So lactase, what it will do? It will convert lactose into glucose plus galactose. Sucrase will convert sucrose into glucose plus fructose, And what this maltase will do, it will convert maltose to glucose plus glucose. And that's it about the breaking down of carbohydrates. And these carbohydrates, after getting broke down, they will directly get absorbed into the small intestinal brush bordered epithelial. They will directly get absorbed. So for that purpose, we broke it down. This glucose, fructose, they are monosaccharides. They will directly get absorbed. After that, receptor for absorption. I guess you don't need to learn this receptor part too much. Like you can just remember that if glucose and galactose is getting transferred, it will be transferred with SGLT1. SGLT1. That's it. And if fructose is getting transferred inside the gut cells, I'll differentiate first. There are two cells present here. This is the gut cell and this is the liver cell. So in gut cell, what it will happen? Glucose and galactose will get absorbed with the help of SGLT1, and fructose will get absorbed with the help of GLUT5. That's it about the gut cells. And in liver cells, what will happen? Glucose, galactose, fructose. These three things will get absorbed with the help of GLUT2. That's it. Defects in carbohydrate absorption. If the intestinal wall is unable to absorb this carbohydrate, it might be due to defect of the enzymes. It might be due to depletion of the layer of the intestine, whatever the reason. So, if there is defect, then it will cause disease. First disease is lactase deficiency. It will cause this lactose intolerance. It is selective. And the second is small intestinal mucosal defect. It is global. Why is it selective? Because only carbohydrate absorption is getting hampered here, not the other things such as protein and uh, fats. But in small intestinal mucosal defect, everything is getting affected. Every absorption is getting affected. So in lactase deficiency, it might be congenital. If it is congenital, it is always autosomal recessive. And in if it is acquired, it is primary and secondary. And that's it. We'll see it further. Proteins. Mechanism of protein absorption. We always know for absorption, we need to break it down. So for breaking down of protein, what we will do, we will use exopeptidase as well as endopeptidase. Here, endopeptidase is enterokinase, trypsinogen. Trypsinogen is further converted into trypsin with the help of enterokinase enzyme. This enterokinase enzyme will only convert this trypsinogen into trypsin. And when the trypsin is converted, it will convert this chymotrypsinogen procarboxypeptidase into carboxypeptidase and chymotrypsin. And they are exopeptidase. These exopeptidase are carboxypeptidase and aminopeptidase. This is activated by trypsin. And this transported inside the small intestinal mucosa with sodium amino acid cotransporter. That's it. Defect in protein absorption. So global absorption. Okay, the layer of the small intestine is depleted. That means it is due to global malabsorption. Global malabsorption. And there are three diseases related to global malabsorption. First is the celiac disease, then is the Whipple's disease, and then is the tropical skew. Third is selective malabsorption. This was global malabsorption. Now this is selective malabsorption. Enterokinase deficiency. If there is enterokinase deficiency, what will happen? This trypsinogen will not be converted into trypsin, and this trypsin, if it is not converted into trypsin, it won't convert this procarboxypeptidase and carboxypeptidase into procarboxypeptidase into carboxypeptidase, and this selective malabsorption will occur. If neutral acids, amino acids transport defect. If neutral amino acids are not absorbed, then it will lead to symptoms like Hartnuck's disease, and it will mimic the symptoms of pellagra, which is 3D. We have learned the 3D symptoms like dementia, diarrhea, and dermatitis. If diabasic amino acid transport is defective, so what are the diabasic amino acids? This is the trick is cola for it. That is cysteine, ornithine, lysine, and arginine. That's it. Then carbohydrate malabsorption. What we have seen here, we got to know what is the physiology of absorption. Then we saw the fat absorption, carbohydrate absorption, protein absorption, and the defect related to protein absorption. Now we will be moving on to the defect related to malabsorption of carbohydrates and defect related to malabsorption of fats. So we are moving on to the carbohydrate malabsorption. First is the lactose intolerance. Here it is written. This is due to the deficiency of lactase enzyme. So physiologically, what will happen? Now the enzyme is absent. Okay, if the enzyme is absent, whenever the patient will consume dairy products such as milk, cheese, yogurt, curd, whatever the milk product he will be consuming, it will not get broken down into absorbable form. So what will happen? It is not getting broken down. So it will stay inside the gut, and the gut bacteria such as lactobacillus, bacteriocytes, and this diabacteria, this all will get, look here, this bacterioids, bifidobacteria, this lactobacillus, they will start fermentation of the carbohydrates which are present inside the gut and which are not digested. They will start fermentation and it will produce methane gas, it will produce H2 gas, it will cause a lot of irritation inside the stomach, it will cause bloating of the stomach, you will get a lot of pain inside the stomach, and this everything will occur within 90 minutes. Okay, within 90 minutes of post-renal. After consuming the product for 90 minutes, after 90 minutes, you will get the symptoms. So the etiology, it might be congenital, it might be acquired. If it is congenital, it is always autosomal recessive. If it is acquired, it might be primary, it might be secondary. If it is primary, it is due to gene defect. And if it is secondary, it is due to infection or inflammatory bowel syndrome. After that, what is the pathogenesis? Pathogenesis, I told you that unabsorbed carbohydrates will move into the colon. Now, these bacteria will be fermenting this carbohydrates, such as bacterioids, this bifidobacteria and lactobacillus, these three bacteria. They will ferment this carbohydrate and they will convert it into H2 gas, methane gas, and CO2. These three gases. And if these three gases are formed, what it will cause? It will cause irritation, it will cause bloating, it will cause cramps, it will cause abdominal distension, and again, 2 3 symptoms. These are very helpful for diagnostic and investigational tests. So this is diaper dermatitis, and see, you will get severe watery diarrhea obviously because there is malabsorption. If whenever there is malabsorption, I have told you it will change the osmolarity. You can find osmotic diarrhea. If fat malabsorption is there, it is pakka osmotic diarrhea. But if other substances such as carbohydrates and proteins are hampered, you will get a watery diarrhea. It will be like chronic type of diarrhea. Failure to thrive, you won't get hungry, you lose your appetite. This is what hyperdermatitis. Children has acidic ears. Look, here is the image. You will see. This is how hyperdermatitis looks. Investigation. Okay, how you will find that the person is lactose intolerant? If he is suffering with the symptoms of abdominal cramps, abdominal pain after 90 minutes of consuming that milk product, he is suffering with bloating. So we will do investigational test. These are the two investigational tests given here. First is the stool pH test. If it is acidic, you can say, okay, he might be suffering with lactose intolerant. If hydrogen pre-test, if hydrogen is more than 20 ppm, you can say that he's suffering from lactose intolerance. And this lactose glucose test, okay, this test is not that much used. It was used before, but it is out of practice right now. Management. How you will manage carbohydrate malabsorption? By just changing the diet of the person. If you are giving no lactose inside the diet, the symptoms will disappear on its own. That's it. And this lactose intolerant people, they are not consuming milk, they are not able to consume dairy product, they will definitely get calcium deficiency. So never forget to prescribe calcium supplements for them. Fat malabsorption. This is the last topic we are covering. This is fat malabsorption. Fat malabsorption has two diseases. We have discussed that A beta lipoproteinemia and intestinal lymphangiectasia. So we'll move on to the first disease, A beta lipoproteinemia. It is also known as neuroacretocytosis. Neuroacretocytosis. Why it is called as neuroacretocytosis? What is mean by neuro? So there is neurological disorder, and enterocytosis. What do you mean by enterocytosis? Enterocytosis means there is defect inside the RBCs. If there is defect inside the RBCs, because in A beta lipoproteinemia, what is happening? It is affecting the FOB48 transporter. FOB48 transporter. This is a transporter protein. If this protein is affected, the chylomicrons are unable to enter inside the blood, enter inside the lymph. It is if it is not entering inside the lymph, okay, the fat percentage will be reduced inside of the body, and we know that the RBCs consist of 52% of fat and 42% of protein. If there is no fat, the orientation of the RBCs will be changing. If the orientation is changed, it is called as ethenocytosis, and it also causes neurological disorder because the fat is lost, so brain also doesn't get its food. So it is neurological disorder. It is called as neuroethenocytosis. So this A beta lipoproteinemia, it is always autosomal recessive. The defect is in the ApoB48, which is microsomal triglyceride transport protein. This is a transporter protein. Defective esterification. If the esterification is also defected, no chylomicrons are formed. This also leads to A beta lipoproteinemia. These are the three etiological reasons. Then there is clinical representation. It is formed basically in triad. I'll show you the triad here. This is the triad: neurological ataxia, steatorrhea, and retinopathy. You know that if there is accumulation of fat inside the gut, it will obviously lead to diarrhea. And hallmark of fat malabsorption is steatorrhea. So steatorrhea will be here. And if fat is not absorbed, you will obviously find neurological disorder because brain is unable to consume its food. And this retinopathy and pigmentosa, and there will be deficiency of vitamins. Majority the vitamin E will be affected. I think I have not added this point, but vitamin E will be affected here. After that, investigation. How you will investigate that the patient is suffering with A beta lipoproteinemia? First of all, you can take blood sample. If you are taking blood sample and if you are finding that the RBCs are misformed, then you can say that the investigation is true and this person is suffering with A beta lipoproteinemia. And postpartum endoscopy. Endoscopy biopsy. If you did the endoscopy biopsy, it is 100% diagnosis. You can find that the person is suffering with A beta lipoproteinemia. There is no doubt. But you should find vacuoles in enterocytes. If there is vacuolation, then only you can say that okay, the person is suffering with A beta lipoproteinemia. And how you will find that vacuolation? With endoscopy. No. Gastrointestinal disorders, which are 100% diagnosis on biopsy. These are Whipple's disease, A beta lipoproteinemia, and A gamma globulinemia. These three are 100% diagnosis with the help of biopsy. Then vitamin E is defective. I told you prior that the vitamin A is defective. Clinical features: ataxia. This is given in the triad. That's it. Then there is second disease, intestinal lymphangiectasia. What is intestinal lymphangiectasia? Intestinal lymphangiectasia. These chylomicrons are unable to cross the lymph. If they are not entering inside the lymphatics, If they are not able to cross the lymphatics, what will happen? It will get accumulated there, and this accumulation will further lead to Crohn's disease and lymphoma. Here it is written. Chylomicrons are fat transported particles. Normally, they pass through the intestinal lymphatic vessels and enter the bloodstream. But in intestinal lymphangiectasia, what is happening? The chylomicrons across the lymphatic blood are unable to cross it. Unable to cross it. Etiopathogenesis, look, lymph nodes obstruction because of lymphatic pressure exudation. This will lead to formation of lymphoma and Crohn's disease. Crohn's disease is like inflammatory bowel syndrome. Obstruction of lymph nodes increases the pressure, causing leaking of lymph into the intestine. Now, what will happen? This chylomicrons are not getting inside the lymphatics permanently, so these lymphatics are getting constrained. They are carrying a lot of amount of pressure there, and this pressure will cause a rupture of this lymphatics. This lymphatics, when they will get ruptured, they'll start leaking substances inside the lumen. When the substances are leaked, majority the protein will be lost. If the protein is lost, if uh, globulin is lost, albumin is lost, they will lead to nephrotic conditions. So first is primary intestinal lymphangiectasia. This primary intestinal lymphangiectasia, it is a rare condition. I'll tell you, it is a rare condition because it is autosomal recessive. Both of the parents should be autosomal recessive, and the gene should be getting inside the baby. So it is a rare condition. And what is happening in this condition? The lymphatic channels are abnormally big. They are abnormally big by birth only. If they are abnormally big, they will start leaking the substances which we are getting inside the intestinal lymphangiectasia, and this albumin will be lost, globulin will be lost, proteins will be lost, and this protein will lead to further symptoms of neuropathy and nephrotic syndromes. So clinically, protein losing causes enteropathy. Most importantly, primary intestinal lymphangiectasia, hypoalbuminuria, and hypoglobulinemia. Edema and ascites are also the symptoms. These are the symptoms that you have to decide. There is nothing that we can do. Edema and ascites, you should be deciding this. You can be giving conceptually that the proteins are lost, so you can say hypoalbuminemia and hypoglobulinemia. Look here. This loss of protein inside the intestinal leads to low albumin. This is nephrotic syndrome and liver disease due to albumin production. So we will be moving on to this diarrhea. This diarrhea majority occurs due to malabsorption of this lymphatic drainage. Now these lymphatics are getting constantly drained inside the small intestine, and this our gut is unable to reabsorb those materials, and it is just flushing it out. So by which test you will identify that he is getting diarrhea due to this intestinal lymphangiectasia? He'll say, okay, fecal alpha 1 antitrypsin. This is a specific test. If you find alpha 1 antitrypsin elevated, you will say that okay, he's suffering with this disease. And if CT scan, you can see if the ball are thickened inside the small intestine. I'll show you this in the diagram. You see here the lymphatics. These are thickened. If there is swelling, they are thickened. Then you can say, okay, he's suffering with intestinal lymphangiectasia. These tests confirm the protein loss and the structural changes inside the small intestine. So how you will manage this? So the management is you will give medium chain of fatty acids. You won't give long chain of fatty acids because this medium chain of fatty acids, they will get directly absorbed, as I have told you before. And this long chain of fatty acid, they won't get absorbed. They should be broken down. And this is the only reason that the patient is suffering with intestinal lymphangiectasia. So here we end our lecture, and thank you for watching. It is the end.